You on 8. You on 8. Okay, you're clear. Stand by for your base.
Welcome back to Loud and Clear EMS Guiding Principles, where we take your learning one step past what you learned in paramedic school, but always connect this back to what truly matters to the patient in front of you. Thanks for your patience as our episode release schedule has slowed down a little bit this summer, but do not fret. We have a ton of amazing episodes already recorded and ready to be released in the near future. Will and I have just been busy working on things behind the scenes. We just recently launched the founding members cohort of our Paramedic Confidence Builders course, and I cannot wait to tell you all about that in the coming months. We also just got back from FastCan in Calgary, which was sold out, packed, and full of just awesome lectures. It was a really great time, and we want to thank Master Medics and Flightbridge for inviting us out there. We interviewed every speaker up there after their lectures, so be on the lookout for those episodes coming out soon. This episode, though, was recorded on site at this year's US FAST conference in Lexington, Kentucky. Dr. Jeff Jarvis, emergency physician, EMS medical director, and host of the EMS Lighthouse Project, sat down with us to dive into the most recent emerging EMS literature and guidelines. Recorded on site at FAST 25 after his talk, Dr. Jarvis presented some of the latest consensus papers from the National Association of EMS Physicians. What are the current best practices for blood use in trauma? What are the most up-to-date trauma arrest recommendations? We even dive into the joint statement recommendations on treating postpartum hemorrhage and severe hypertension in pregnancy. And of course, because I couldn't help myself, given this opportunity to sit down with such an expert in pre-hospital data and research, I had to ask him about the current literature on field intubation times, pre-hospital treatment of Afib with RVR, and a sneak peek of a study on pre-treating with calcium before Diltiazem for Afib patients. Don't miss out on this information-packed episode on best practices backed by evidence in the pre-hospital setting. Lastly, before we get to the episode, I need to give my most heartfelt thanks to our sponsor, the Resuscitator. The Resuscitator has been a huge support and made this free educational content for you possible. Not only that, but we truly believe in their mission of improving outcomes in EMS through thoughtful design. Creating bags that are custom designed for your mission, so that you can build the bag around the equipment you need rather than deciding what equipment to bring based on the limitations of your bag. Please go check them out at theresuscitator.com. Reach out to them via their contact page. They'll even help you design a bag to beta test and iterate on before deciding on the final product. You too can support this show by supporting them.
Line clear, number 2, go ahead.
Jeff Jarvis, the host of the EMS Lighthouse Project, physician and EMS medical director in Fort Worth, Texas. We're here on site at FAST 25, and you just gave a great talk on some of the emerging literature in EMS, and more specifically, some consensus papers and guidelines that are coming out of from NAMSP, or a compendium on kind of recommendations in trauma. And so thank you so much for sitting down with us. Really excited to have you and talk about some of these papers.
Thanks for having me on.
So the first paper was blood in trauma. What do we need to know about that?
So first off, they really went to great lengths to say blood is good, but if you don't have it, it's okay. Don't beat yourself up. Try to get it. But if you don't have it, you can't give it. So it's nice to just start with the things that we all know. I personally, before we had blood, was getting really tired about getting beat up about this patient needs blood. Yeah, we got that. We don't have it.
Yeah.
So I think most of these compendium papers are very realistic, and I like that. The other thing, and I'll get back to the blood, but about all of these compendium papers, is they're based on a really good methodology for a systematic review. So Dr. Martingale does a great job of bringing this method to all of the trauma papers. So what you'll see when you open up the article is the recommendations. That's the position of the board of directors of NAMSP. Then you'll see a resource document, and that goes in and summarizes the literature. So know that all of these recommendations are based in literature. So I like that. So they say, if you have blood, use blood preferentially over crystalloids. If you have blood and you have whole blood, use that preferentially over components. So we like blood, we like whole blood more than components if you have it. But if you don't have whole blood and you do have components, giddy up, definitely use that instead of crystalloids. They talk about using physiological indicators and not just mechanism of injury. So if you have a gunshot wound to, say, the femur, and there's blood all over the place, but their blood pressure is, it's a 20-year-old kid, no beta blockers, nothing to control his rate. His blood pressure is 130 and his heart rate is 60. Might not, and there's no ongoing bleeding. You might not need that. On the other hand, if you see signs, shock index is like 2. Your heart rate's 120 and your systolic 60, giddy up. Give the blood for that. So use physiologic indicators, not just mechanism. They also talk about the importance of actively monitoring for adverse events. Now, adverse events, as our colleagues from San Antonio have shown in a recent paper, are very rare with blood, but they can still happen, and it's important that we're actively looking for them. And then they mention that if you're using blood, you really need to set up an exchange program, meaning if you have a 28-day bag and day 14 rolls around and you haven't used it yet, get an agreement in place way before you get the blood to go to, say, a trauma center that's using whole blood all the time and has a much higher likelihood of using that blood. So set up the exchange program. Then the last thing they talk about, I summarize as it takes a village. There are a lot of things, droperidol, ketamine, that we can do as medical directors, especially if you're in a delegated practice like the great state of Texas. You can just put it out there. You're not going to harm anybody else. Just make sure the literature is good and you can do it. Blood's not one of those things. You really need to focus on doing this on a regional basis.
Yeah, that's a very good point. I think that's one of the biggest barriers for most of us out there. I mean, in my own agencies, as we've looked into just a region, we're trying to take a regional approach because we work in a pretty rural area, and how we can share the blood with the regional hospitals and rotating it. Interesting, you guys just implemented it in your own system.
We did.
And how many units do you have out on the street?
So it's been escalating. Okay. Right now we have 4. We started with 2. We're going through some changes in Fort Worth. Fort Worth Fire Department is bringing EMS in-house. So MedStar, the public utility model that's been there forever, is going away. Fort Worth Fire is taking over, and we are building a tiered system. So roughly 60% ALS, 40% BLS. And then we're going to have critical care paramedics in fly cars. So board certified critical care. They're going around just doing the high acuity stuff. They'll have the blood. And we're trying to ramp up between now and July when we go live. Eventually, we'll have 8 of these critical care paramedics, 1 dual role, so fire that's designed to do controlled spaces and collisions where you really need those special skill sets, plus the critical care. And then we'll have 7 other critical care paramedics, 1 per battalion. They will all have the capability of carrying blood. Whether they have blood or not is entirely dependent on what our data shows, and we're building that data pool now. We really need to analyze what is the right ratio of blood available. So with 4 units of blood, so far in about 25 days, we've given 21 units, and we've not had to exchange any blood. And we have a JPS, our trauma center, one of our trauma centers, wonderful partner with us. They'll exchange the blood, but they haven't had an opportunity yet because we're using it.
Yeah.
That's good. But I also have no doubt that we have patients, and this is the analysis we have to do, who could have benefited from the blood, but it wasn't theirs. So maybe we need 5, maybe we need 6, maybe we need it on all 8. We're still trying to balance that and figure out what the right area under the curve, how we're going to figure out the ratios.
Did you guys do any of that analysis before you implemented it? Or were you like, we'll just start low and then we'll start doing the analysis and see how much we need?
The analysis we did was not geographic. It was system-wide. How many units do we anticipate we're going to give? And we're right about where we thought we were. And those are based on just physiologic indicators. Yeah. And we're right about where we were there. Next up is where we're going to have these located. And that's going to be, heat map it out and figure out where the best place to put it is.
Okay. Well, thanks for letting me pick your brain a little more about that little tangent.
I'll tell you one thing that's interesting about this.
Yeah.
So if you think about implementing a whole blood program, you're probably thinking you're going to be giving it to MVCs and trauma patients and gunshot wounds. Of that, for early days, right? It's just 21 units. 12 of them, 57% went to trauma. Kind of what you'd expect.
Yeah.
But that's only 57. 43% went to medical patients, including a non-OB related, non-pregnancy related vaginal hemorrhage. Some woman managed to fillet open varicose veins and didn't get the bleeding stopped in time. Blood pressure's like 60 when we got there. Post-op, just some bizarre things that I certainly never thought about.
Yeah, that's interesting. One of our recent episodes actually came from a request from a listener about, hey, can you talk about when to give blood in like GI bleeds, like cases outside of trauma? So we recently just did an episode about GI bleed and similarly like when to think about giving blood. There's a lot of other reasons people bleed outside of just your car accidents.
Exactly. We're doing a lot of GI bleeding. There's not great literature. But when you have somebody who has filled up multiple suction canisters of bright red blood, upper GI bleeding, probably varicose, and their blood pressure is tanked and their heart rate's there's no way we're not going to treat that with blood in the hospital. I got the blood there, and it turns out stabilizes their vital signs just like you thought it would. So,
The point I made in the episode was it's similar to trauma in that we want some permissive hypotension.
Right.
There hasn't been studies on what blood pressure of when to give a GI bleeder. But there has been studies on like hemoglobin levels, and the GI bleeders actually tend to do better when you transfuse at lower hemoglobin levels. So that idea that you may be creating more back pressure to those varices. So similarly, permissive hypotension. But if the systolic is less than 90 and you have those shock indicators, you got to give it.
It was really helpful. So I was on call. We didn't anticipate using a lot for medical calls. We didn't anticipate doing a lot in LTACs. And I was on call that first week we went live with blood. I got a call from an LTAC. This is the GI bleeder. And the bleeding started 2 hours ago. And I knew what his hemoglobin was 3 hours ago. And it was 7. And I'm looking at, liter and a half, and I'm like, that didn't improve it. And his blood pressure is 60. I'm going to give the blood. I'm feeling pretty good about this.
Exactly.
Yep.
All right. Well, bringing it back to these papers, the next thing was trauma arrest. And there were some kind of keys to that. And the first was identify the proper patient who may benefit from transport.
Can
you tell me any more about that?
Not a damn thing more. It was... I wasn't involved with I didn't do any of the trauma compendium papers, so I don't know. I have a funny suspicion because I've lived through this with other papers, that statement, and it basically said rapidly identify patients who would benefit from rapid transport and transport them. Great. What patients are those? Nothing. Crickets. That was reviewer number 2 saying he's digging in. We got to have this. Okay, fine. There.
So given, and it sounds like there's just not much data to like what patients we know will actually benefit from this. So in a data-free zone, what are you telling your crews
for transport?
Patients?
So there's always the question of let's just go on the assumption that every patient with thoracic trauma that you bring to the ER is going to have their chest opened up. Now we know that's not true, and it shouldn't be true, right? Our surgeons they love to cut, but they're actually trying to only do it when it's useful. If I can get the patient on the ER table in 3 minutes, I'm going to transport them. Pregnancy related ones, if we can get the fundus off of the vena cava and get the patient there within about 5 minutes, then I'm probably going to transport. That's great. That almost never happens unless the shooting happened in the hospital parking lot, right? It takes way longer. So I'm having a hard time thinking which patients that are in arrest when we get there. Now, the ones who you're already transporting and they arrest, different situation. You have the operational challenges of now what do I do with the patient? we're really not transporting. If we don't get them back, we're not going to transport them. Outside of they got shot in the parking lot.
Yeah. Very near to the hospital.
Yeah, so I just don't know what to do with that statement.
Yeah, that's fair. The next thing is prioritize.
Yeah.
Prioritize your treatments.
Yeah, they really first off, I wanted to go back to the name. So they call this traumatic circulatory arrest as opposed to traumatic cardiac arrest. And the idea here, it's kind of, pedantic. It's what's the difference in a word. They're trying to get a point across the point that our approach to medical arrest is dramatically different than our approach to traumatic or medical arrest and trauma. I don't know which one I said there. Medical and trauma are different, and you got to treat them differently. So that's why they're trying to emphasize circulatory arrest, because there really is a circulatory problem. It's not a VFib problem. If they're in VFib, you really probably ought to be thinking, is this really trauma?
Right.
And treat that like a medical arrest. So they make that point. If you're not sure, treat it like a medical arrest. And then they say the things that you do have to be focused on the life-saving interventions, the things that you can do to reverse this. So they identified a couple of them. If it's bleeding, stop it. Stick something in the hole, put pressure on it, put a tourniquet on. If the airway is obstructed or occluded, fix that. Open the airway and make sure you have oxygenation and ventilation using the least invasive methods possible. It's not because we think intubation is necessarily bad. Now, it may be, but it's just not the question they're answering. It's that if you open the airway just with a jaw thrust and some ventilation and oxygen, and that didn't solve your problem, that's probably not the problem. You should keep looking. Chest decompression. So we know traumatic tension pneumothorax, big reason for cardiac arrest, just circulatory collapse. So they say your go-to should be needle decompression, and you should only do it with suspicion of a tension pneumothorax. Okay, really what does that mean? What it means is stop doing the empiric all circulatory arrest, get needle decompressions. I got to tell you, I'm feeling a little targeted by that because that's exactly what we were doing. We were doing what a buddy of mine, Jay Kovar, called the 3-hole punch. So punch, 3 holes, empirically on all traumatic arrest. There were a couple of patients with self-inflicted GSW wounds to the head who are getting this, and I'm like, yeah, maybe that's not really what I meant to write. So I think that's their point.
Yeah.
They talk about, so simple or needle decompression should be your go-to. Then full thoracostomy if you have the correct training. So high functioning systems for training, do simple thoracostomies.
Yeah. Okay. And so in your mind, if there's evidence of trauma to the chest and they're in traumatic
close enough for
circulatory
me.
arrest,
Open them up somehow.
Yeah.
Yeah, and I really don't think there's much downside to doing simple thoracostomies.
Yeah.
But these are literature-guided papers, so they really had to stick within the evidence. Evidence says just stick with needles.
Yeah.
We know there's also a lot of evidence that said in our Texas-sized populations, that needle ain't getting where you think it is.
Yeah.
So just use the scalpel.
Yeah.
So, but that's Jeff opinionating, not the paper.
Data per se.
The other thing I think that was helpful about that particular paper is what they said not to do. They said stop using epinephrine in traumatic circulatory arrest. They said cardiac chest compressions, very unlikely to have any benefit. If you must do them, don't let those compressions interrupt the things that are important, the life-saving interventions. And then the final thing, well, 2 more things, I'm sorry. No specific duration of resuscitation. A lot of us have 20 minutes of resuscitation or 40 minutes before termination. There is no data to suggest any duration in traumatic circulatory arrest. And the final thing that I think is really helpful to a lot of us is they said don't let cost to the patient or the opportunity to do organ donation impact your decision about whether to transport or not. They made the point that something like less than 1% of all successfully harvested organs come from traumatic arrest, and they arrested in the hospital. We're just not going to be able to get them there. So don't let that be the sole determinant about whether you transport.
Yeah, I think that's fair. There's no data on the timing, but I certainly think in my mind, if they're not coming back with blood and those initial interventions,
Yeah.
it's hard to see, working somebody for 40 minutes, getting that person back with any sort of viable outcome.
So they didn't really address blood in traumatic circulatory arrest, and they didn't really address traumatic circulatory arrest in blood. I think we have a real ethical dilemma on our hands there. They're dead from traumatic arrest. Pretty decent chance they're hemorrhagic shock. We have blood. Why don't we give it to them? Well, because we have to treat, this is population health. The EMS is public health. We have to deal with the entire population. What about the next patient that needs blood that we don't have because we gave it to the person who's been in circulatory arrest for 30 minutes? The blood's unlikely to help. So we have to figure out a way to balance that. I balanced it by saying if they arrest in front of you, so EMS witnessed traumatic circulatory arrest, and you essentially already have access, the blood can get into the patient in under 5 minutes, then do it. No evidence whatsoever for that. I had to do something, that's what I did.
Yeah.
And basically I blatantly stole it from San Antonio.
And I think physiologically that makes sense too. If somebody truly arrested because they exsanguinated, that tank is truly empty, you're not filling that tank with 1 or 2 units enough to get pulses back or meaningful organ perfusion back. So I think that physiologically makes sense without any data.
Yeah.
Great. So I think the next one was talking about, and I don't know if this was the same paper or a separate paper, thoracostomy specifically.
Yeah, it was a position statement on traumatic tension pneumothorax. Big take-homes here, there is a difference between a simple pneumothorax and a tension pneumothorax. Everybody should understand the difference, and we shouldn't be sticking needles in chest in simple pneumothoraces. We should only do it in tension pneumothorax. And they say, again, use your physiological markers for identifying tension. They strongly hinted but didn't come out and say it. I come out and say it when I'm teaching. No hypotension equals no tension equals no needle. So if they're not hypotensive, don't decompress them. Now, that's for field protocols. We're probably going to put chest tubes in a lot of patients that aren't hypotensive in the ER. That's a different population of patients. So I'm clearly not saying never decompress a chest with a pneumothorax without tension physiology, but we probably shouldn't be doing it in the field, and that's what the position statement says. So they again recommend needle, then simple thoracostomy, and don't do it blind. They really reinforced each other on that one.
Yeah, good. The next one was postpartum hemorrhage.
Yeah. So this is obviously not part of the traumatic compendium. This is a partnership between ACOG, the American College of Obstetrics and Gynecologists, and NAMSP. ACOG has been really focused on decreasing postpartum hemorrhage. Understandably, it's the #1 cause of mortality in pregnant women in America. So this is something we can do something about. They make a couple of recommendations here. Do fundal massage, gentle traction on the umbilicus, gentle being the key word here. Do a fundal massage, give oxytocin. So if you don't have IV access, give 10 units IM. If you do have access, give 20 units in a liter, run that in wide open. Some interesting recommendations for misoprostol. I'm in Texas. I don't know if you know this, but the political environment around anything to do with any type of abortion, let me just say that, is charged. Misoprostol is an incredibly safe drug, perfectly reasonable to use it after miscarriages completed to stop postpartum hemorrhage. Perfect reason to do that. I'm not doing it in Texas. If I'm having to explain to legislators who really aren't all that interested in the explanation, the difference I've already lost, I'm sticking to oxytocin.
Yeah.
And then they also still are recommending TXA. Interesting, there is one FDA-approved indication for TXA in the United States, and it's not gunshot wounds.
Yeah.
It's postpartum hemorrhage.
Yeah.
So from the woman's trial.
Yep. Exactly.
Woman trial, not women's, woman. Interestingly, they're still sticking with the 1 gram bolus and then 1 gram over, the next 8 hours, instead of going to what most of us are using is 2 grams. They're just sticking with what the evidence says, and that's from the Wolfen trial.
Yeah.
So that's postpartum hemorrhage.
Yep.
Pretty straightforward stuff.
Yeah. Along those same lines, hypertension and pregnancy.
Yeah. This one I think is interesting. I think we all think about eclampsia. If they're hypertensive and seizing, we should do something, give a MAG. I think we all got that part. But these recommendations, and they're The post that we put out within AMSP is just the guidelines. There is no reference document. You got to go to ACOG to get those, but they do exist. It's based on good science. It's based on the difference about what's going on in the placenta endothelium, and it took me about a paragraph to get way over my head physiologically. I'm going to take their word for it.
Yeah.
We should treat it. It's bad. This is different than hypertension in the non-pregnant patient, where we used to give nifedipine all the time for hypertension in just the general population. We don't do that anymore because it worked. What we found is that we lowered blood pressure and we caused ischemic strokes. So chronic hypertension, different population than the pregnant patient. So we're talking post 20 weeks all the way up to 6 weeks postpartum. If they're hypertensive, and they define this as a couple things. So if you are greater than 140 systolic or greater than 90 diastolic, and you have symptoms, new onset headache or blurry vision, right upper quadrant pain, then give MAG. But don't treat the blood pressure with anything, with antihypertensives, just MAG. But, and the little diagram has green, yellow, red. The red is systolic greater than 160 or diastolic greater than 110. In the absence of symptoms, no symptoms, doesn't matter, lower the blood pressure, give MAG, and then give nifedipine or labetalol or hydralazine, and be aggressive about it. So both for the labetalol and for the nifedipine, I think they say the same thing about hydralazine, but unless you have a gun to my head, I try not to use hydralazine. Their starting doses start at labetalol was 10 and nifedipine was 10, and then doubled. And then doubled. And they're like, no, seriously, lower that damn blood pressure. So.
Yeah, I laugh because in emergency medicine, we do hate hydralazine, and there are reasons for that. There's erratic absorption. Everybody metabolizes it differently. The peak onset is different for every person. It's just a very not predictable medication.
Right.
But
this is a different population.
it's a different population. And for, I don't know if you know why, but ACOG does recommend that first line. So I was just sitting on a state waiver panel because in Colorado, we do not have delegated practice.
I am so sorry.
I know. And one of the agencies was applying for a waiver for, and one of the questions came up, why not labetalol? It's, you know, quicker on, quicker off, more predictable. We have comfort with it. And the response was, well, this is what ACOG recommends first line.
Yeah. When I'm looking at those guidelines, I don't see the first line. I'll go back and look again because certainly I may have missed it. What I saw was, I thought fairly clear that it's dealer's choice. And what that means is there's probably not a lot of evidence that one is better than the other. And if they're all more or less equal, then operational concerns can take over. There are other things I can use labetalol for. There are other things that I can use nifedipine for. I'm probably not going to, especially with nifedipine, but I like labetalol. So that's the reason I'm going to use it. I'm probably not going to use it for anything outside of IFTs where I know they have a head full of blood, but I have the option of using it for something else. So two options for the price of one I like better than, I don't know what else I would use hydralazine for.
Yeah, that makes a lot of sense. Moving on, there was a paper looking at the time to intubation and outcomes.
Yeah, so this is one by David Murphy and his colleagues in Seattle, single system observational trial. They went back and they looked, well, I shouldn't say a trial, it was a cohort study. They went back and looked at, they have a wonderful registry for their arrest patients. They have data from CARES, so they know the patient's outcome. We know that interrupting chest compressions, certainly for an extended period of time, is bad. We don't want to do that. So we've spent, man, I got to tell you, here at FAST, I'm smelling really good food over there.
It's starting to heat up.
Starting to get distracted. Great job, Powers. Y'all did a wonderful job. Seriously, if you get a chance to come to FAST, come to FAST. It's a wonderful conference.
Absolutely.
One of my favorites.
Yeah.
And I completely, that smell of food has me so distracted.
Yeah, time to intubation.
Time to intubation, yeah. So we've done a great job making sure that we're intubating with ongoing compressions. We know first pass is important. David Murphy also did a paper that showed a huge drop, above 60% increase in mortality with each additional missed intubation. The first pass is important. So then why don't you just stick around in the airway for a long period of time, as long as you're not interrupting compressions. I say that sarcastically. I might have taught that. And this paper comes along, and what he was trying to ask is, well, how long do we go without ventilation? Because we're starting to see some emerging evidence that ventilation is important. His answer, what he did, the methods are really interesting. They audio record all of their cardiac arrests. They obviously have waveform capnography. They can see when they gave the last ventilation prior to intubation and when they gave the next. They can see the waveform. They know all, and they have video laryngoscope, so they can see this. So the median time was 83 seconds. The 75th percentile was something like 113 seconds. So it's taking longer than we think it is. Okay, great, so what? So then they said, let's take a look at those patients who get intubated in under 60 seconds and compared to those who get intubated in longer than 60 seconds. And what they found is higher ROSC, higher survival to discharge, and higher neurologically intact survival if the tube is in place under 60 seconds. They use logistic regression, controlling for all the things they can control for. Still a cohort study. Obviously, it's not randomized. It's highly suggestive that if you're in there and you're just mucking around, cut bait and drop a super vlog.
Yeah, I like that. As a little bit of a background, actually right before your talk, Dr. Peter Antebi was up there discussing some other research. One of the ones he brought up was a study that looked at ventilating with ongoing compressions versus doing our standard 30 and 2.
Yeah.
You want to talk about that? Just give a little background.
I'd love to. I spent a fair amount of time, not nearly as much time as I would like, doing a deep dive into the literature on the effectiveness of ventilation in cardiac arrest. The reason I say not as much time as I would like is because there's just not much data. A lot of data on compressions, not much data on ventilations. Why? Well, because the light's better over there. You rob banks because that's where the money is. We have data on compressions. We don't have great data on ventilations. What we have is the ROC trial that compared 30 to 2 to continuous compressions. Now that trial, as a reminder, showed no difference in overall outcomes. Well, there was a subsequent paper, and this is one of the things Peter talked about, that did a secondary analysis of that. One of the reasons there was no difference is 30 to 2 CPR is hard, and they didn't actually get it done very often in that trial. So it's mostly done poorly. So this secondary analysis said, well, what about the patients who actually got 30 to 2 versus those who actually got continuous? And survival was higher, meaningful survival higher with interrupted 30 to 2. So that is kind of setting the stage. Next up is how about ventilation? So they took the patients in the 30 to 2 group who actually got 30 to 2, and they looked at ventilations before an invasive airway. And the reason they did that is in that trial, as soon as an invasive airway went in, they went to continuous compressions, like most people do. So they basically looked at, there were 2 papers that came out. That paper, that was by Dr. Idris, and another paper out of Spain by a guy whose name starts with an AZ, and I can't remember the last of them. One looked at variations, fluctuations in the end-tidal CO2 waveform. The other looked at impedance channels from the multifunction pads. The Idris paper basically said, were the ventilations effective or not? And they were very rarely effective ventilation. So you just weren't delivering, you essentially were not delivering enough tidal volume to overcome dead space. And they said, well, that's not good, and it's happening all the time. So most of our ventilations are crap. Then they said, well, let's take 2 groups in this. We'll break the group up into those who had more than 50% effective ventilations and those who didn't. Survival was higher in the group with effective ventilation. So it seems effective ventilations matters. Now the other paper, and I believe they did that with impedance channel monitoring. The other looked at patients with invasive airways with ongoing compressions. And they were looking at the variations in end-tidal CO2 waveform. And they wanted to see how much tidal volume were we delivering to the patient at the lung level versus when you're doing continuous compressions. And the idea here is you're doing chest compressions to increase interthoracic pressure, decrease interthoracic, increase, decrease. You're creating a pump. to suck blood in, but you're also pushing air actively out. So if you're pushing air out, at the same time you're trying to push air in, your vectors hit and you negate what you're pushing in. We just don't know the extent to that. What he found is very frequently we are not delivering enough tidal volume to overcome minute volume. Now, this is far from conclusive, and I want to be really clear. I don't think this is conclusive evidence, but it certainly was enough to push me over the edge, and I went back to 30 to 2, and we will drop a supraglottic as soon as we get there. I have 1,600 people to train how to mask ventilate. It's easier to teach them how to drop a supraglottic. In Texas, delegated practice, we can do that. So we continue, even with an invasive airway, to do interrupted ventilations. So, and that's why.
Yeah. When's somebody going to come up with a ventilator connected to the automated CPR devices to time them for us?
That's a really interesting question. I think a good start would be to show some benefit to the mechanical CPR devices, something we haven't done yet.
Yeah. Well, so we actually did a whole episode
to patients. Let me say that.
Yeah.
I'm convinced of the benefit to clinicians.
We did a whole paper on, there was that recent, it was a few years ago, systematic review of all of the literature where they concluded that,
I love this conclusion.
I know, any future studies would be futile. So please stop studying it. I love that.
I quote that all the time. That's the best part of that paper.
Exactly. But when we say that, people get upset and they say, "Oh, you're telling me that it doesn't work." It does work, just as good as our hands.
Well, I'm not sure that's true. So if you go back and look at the paramedic trial, so paramedic 2 was epinephrine. If there's a paramedic 2, there had to be a paramedic 1. That was a randomized control of mechanical CPR. And what that trial did a great job of goalpost moving. So we're starting off looking for superiority. They didn't see it, but they said, well, we're not seeing inferiority. Therefore, if the outcomes are the same, there are operational reasons that you would do this. So equivalency is what we're looking for. That's not what you were looking for. You were looking for superiority.
Sure.
You did not see this. You did not set this up as a non-inferiority trial. Those are two different methodologies. There was a study in Austin that Luis Gonzalez was the lead author on. Dr. Lawrence Brown was one of the co-authors. And I can hear, when I read this, I hear it in Lawrence's voice. What they did is they implemented Lucas devices in Austin, trained their butts off at minimizing interruption, doing it just like Mike Levy has told us, really doing it right, and survival dropped with the Lucas. Yeah. That's real world. And it's not just Austin. It happened in Vienna. It happened in the entire state of Utah. It happens in the Get With The Guidelines in hospital. So what you're actually seeing is decreased survival in the real world. And what I hear Lawrence saying is there are a lot of arguments that there may be a subpopulation that this is beneficial for, but we have never found it. And the argument is, well, if there are equivalent outcomes, then operational reasons might argue in favor of that, which would be true if outcomes were equivalent. And there's a lot of building evidence that they're not equivalent. Now, just to be clear, I'm not arguing don't use them.
Yeah.
I don't think the question is if you should use them. I think the question is when. And I think that the evidence, and even in it was either the Aspire or the paramedic, and sorry, it's been a while since I've looked. They looked at patients who got ROSC within 0 to 5 minutes, 5 to 10, 10 to 15, and so on. If you got ROSC within 5 minutes, they compared ultimate survival between MCD, mechanical compression device, and manual. Survival was much higher with manual early on. 5 to 10 minutes, still higher with manual. 10 to 15, now it's higher with mechanical. So you see, and they have a nice graph, and it's clearly a time-dependent relationship. So I think early use of an MCD is highly likely to lower your survival. Delayed use, I think I don't know if it's going to increase survival. That data would suggest maybe it does.
Yeah.
But the vast majority of patients, 90% of patients who are going to survive, will get pulses within the first 10 minutes. That's where the important stuff should happen. Focus on doing really good CPR for 10, 15 minutes. Then you're exhausted, no matter how many resources you have. Then bring the MCD in. And use the lessons Dr. Levy and Anchorage taught us about how to apply it.
I agree. In my own personal practice is to do hands-on CPR right away and to not mess around with not having compressions and trying to get the device on because your greatest chance at getting that person back is immediate.
Yeah,
and then
exactly.
And then if you can't because of operational reasons. And they, in that big systematic review, they did attempt to go back and look at subpopulations that maybe did better. And what they found was longer arrest times, asystolic patients who didn't receive bystander CPR, and limited providers on scene were like the few scenarios where it maybe suggested some benefit. And so I think that goes along with what you're saying.
And I think if you go back, even my protocols talking about the limited rescuer, okay, I don't need data to tell me that if you're the only person there, put the damn Lucas on. That just makes sense. And for the love of God, if you have to transport with CPR in progress, this is now about you, not the patient.
Right.
Use the MCD. The only reason you're using the MCD for your safety is so you can buckle up. For the love of God, don't put them in an MCD and then not wear your seatbelt.
Right.
I want to make sure you go home at the end of the shift. So
I like that. This last paper, I want you to just tease it for us because as I understand it, you're actually going to cover it in much more detail on your own podcast, the EMS Lighthouse Project. And so tease us with this.
Thank you.
You're welcome. Tease us with this and then tell us where the listeners can go find that more detailed episode.
So plugging future podcast, the sign of a quality podcaster. Well done, sir. Well done. Yeah, the next episode, I'm going to look at this paper. This was a single study emergency department paper in, I want to say it was Istanbul. Small, it's not a multi-center, but it was a randomized controlled trial. It was placebo-controlled in the emergency department of adults with AFib or a flutter with rapid ventricular response, narrow QRS complexes. They excluded the patients you shouldn't give calcium channel blockers to. So history of WPW, wide complex, any of those things that suggest aberrant pathways. And they said, what we want to do, the whole idea here is we're going to treat with Diltiazem. So all patients got 0.25 milligrams per kilogram, slow IV push Diltiazem. We know that Dilt can lower your blood pressure. Okay, got that. And patients in AFib RVR, depending on their rate, may have lower stroke volume, therefore lower cardiac output, and Dilt might lower the blood pressure. Well, it's probably going to lower the blood pressure. We actually know that. The big question is, does the lower heart rate compensate for that? And in most patients it does, so just lower the rate. What they were trying to figure out, though, is if you pre-treat your calcium channel blocker that you're going to give in the Diltiazem, if you pre-treat with calcium, does that blunt the lowered blood pressure, right? So do you see less hypotension? They also wanted to see if you give the calcium first and there's no hypotension, that's great. But if you're not also lowering the heart rate, then why the hell are you giving the Diltiazem? So that's what they did. 3 groups. The control group just got saline bolus plus the Diltiazem. Then their 2 interventions either got 90 milligrams of calcium chloride, and 90 milligrams elemental. Remember, the gram of calcium is not elemental, that's of the calcium chloride. The little yellow box, by the way, is about 273 milligrams of calcium. So just to give you an idea of what they're using, probably not. Is this something you've ever done, calcium before Dilt?
No, it's not.
I've done this. I did it every time for a while. There was a paper that said, yeah, it's not really working. So I kind of just started doing it when the blood pressure was kind of iffy. So I cut back on my practice. But I had been doing it. When I did it, I gave 273 milligrams. So I gave the full gram. So this is less. They did 90 milligrams or 180 milligrams. And then they compared the delta heart rate and systolic blood pressure at 0, 5, 10, 15, and 20 minutes. And basically the bottom line, none of them, even the 180 milligrams, impacted the heart rate. All of them dropped. You got AFib RVR under control. No need for additional dose of calcium channel blocker. It's great. So you can give the calcium without the adverse event of having to give more. What about hypotension? So there was more hypotension with placebo than there was either 90 or 180. There was less hypotension with the 180. So the calcium does seem to be blunting it. Now, the way that they did their statistical testing, I'm not a fan of. They were looking at measuring systolic blood pressure as a continuous variable. I think it was just unnecessarily complex, and it's not what I care about. What I care about is, did I get control of the rate? Did I have to give more? So they looked at that well. And then I want to know, did I cause a problem that I now have to fix? And they didn't really answer that question. It doesn't look like it. They looked at composite adverse events, and there was no difference. Overall, it's not the best data, but it's a nice paper that agrees with my practice, so I like it.
Yeah.
That's the best research, is the one that is well done and it agrees with your
Reinforces
practice.
your practice. I'm interested to hear your take on treating AFib with RVR in the pre-hospital setting.
Yeah.
Because, personally in my own practice, when I trained in residency, the best data that was out there on the emergency setting of treating AFib with RVR was a retrospective cohort paper that looked at, I think it just looked at metoprolol, and found a drastically increased adverse outcomes in patients who were treated with metoprolol who had AFib RVR in the emergency department. And so the training and the concern that I've always had is oftentimes AFib with RVR is a compensatory mechanism for the patient to be able to increase their cardiac output because of some other underlying etiology.
Sure, often.
First and foremost, we need to make sure there's no other underlying etiology going on. So
yes,
I have classically sat on these patients for a while in the emergency department just to extra assure myself that there's no other underlying etiology, and this really is just AFib with RVR.
Wait until the C-reactive protein comes back or something else helpful like that. Yeah. So you raise a really good point. Interestingly, when I came to Fort Worth, they had stopped treating AFib RVR. We treated it all the time in Williamson County, where I was medical director before. But that was where Sun City was. Everybody was old. I mean, the older you get, the more likely you are to go into AFib. It's like men. It's not when we get, or if we get prostate cancer, it's when. So everybody was in AFib. We did it all the time. I don't see the problem. And what they said is, we're treating it when the problem is they're septic, or there's some compensatory mechanism. So yes, there's that. The reason I think we should do it is because at pre-hospital, I'm going to blow your mind with this one, pre-hospital treatment of AFib RVR in the field, not in the ER, in the field, lowers mortality.
I saw that recent study, and lowers length of stay in ICU, and it was a single data set.
Fewer calories, taste better
from ESO.
Yeah.
There was also a recent in-hospital study that similarly showed decreased mortality with treatment of AFib with RVR, even in congestive heart failure patients. We've been classically taught.
Yes,
I love this. No. And so I'm starting to change my mind. I don't know.
Go back to that.
Yeah.
What's the no-no?
Giving beta blockers in a decompensated CHF patient.
Or definitely Diltiazem.
Sure.
So the calcium channel blockers.
Sure.
Cardiologists hate them.
Yeah.
What's the EF? I'm like, I don't know what the EF is. They're like, you can't give a calcium channel blocker. I'm like, I can guarantee you, I have given DILT in patients with an EF that's low. But you know what else patients with a low, their point is use a beta blocker or use something. Yeah. Okay, I'll get that. I hate metoprolol with a passion for AFib RVR. In the absence of evidence, the evidence says either one works fine. In my experience, if I really want to admit them, I'll treat them with metoprolol because it ain't going to work, and then I'll admit them. If I want to have a chance of sending them home, anticoagulated, all that, then I'll use DILT. Yeah. But it seems to lower mortality. Yeah. So I think that's the argument in favor of it. Yeah. The key thing there, though, is they had some exclusions.
Yeah.
If you had a temperature, they excluded you because it might be sepsis. They excluded you if there was trauma. Those are reasonable. That's not, you can call that a limitation of the paper, and sure, it's a limitation. But that's who we should be treating and not treating. So when we brought DILT back, we were really clear that if they have a fever, if you think this is sepsis, if they're coughing, stop doing it. If, any type of trauma, pick your patient population well. Just.
Yep. My mind's changing.
Yeah. We'll get you there.
Yeah, all right. Well, thank you so much for coming on. I really appreciate it. Tell our listeners one more time where they can find you. And
so EMS Lighthouse Project podcast, wherever you get your discerning podcast. So we're part of the Flight Bridge Ed Network, which is one of the reasons that I love being here at FAST. And then we also have a YouTube channel. So all of my videos I do on YouTube.
Cool. Awesome.
Yeah. Ross, thank you so much, man.
Thank you. Let's do it again.
I appreciate it.